Good afternoon. What a great room. I am Lisa Blanchard, the president of the League of Women Voters Northern Lower Michigan. And on behalf of the League, I welcome you to our public forum today on palliative care. Our health committee has organized this forum, which is being recorded, and it will later be posted to our YouTube channel, which you can find on our League website. The League of Women Voters of Northern Lower Michigan acknowledges that the land we serve is the traditional territory taken from the Anishinaabe tribal nations. And especially we acknowledge that just 2 days after Indigenous Peoples' Day. We honor the tribe's role in taking care of this land, and in offering this land acknowledgement, we affirm Indigenous sovereignty, history, and experiences. And for those of you who might be new to the League or unfamiliar with our work, we are a nonpartisan political organization that encourages informed participation in government. We work to increase understanding of major public policy issues and influence public policy through education and advocacy. We do not support any political candidate or any political party, but we do have positions on public policy, and these inform our advocacy work. So we're so glad that you've joined us. And for people watching on Zoom, please change to speaker view on your screen if you aren't already there. And we can mute your microphones, but I think most of you were already muted. It's now my pleasure to introduce Martha Lancaster, who will introduce our speakers and explain our question and answer procedure. Thanks, everybody.
Well, thank you all for coming and joining us on Zoom. I am a member of the Healthcare Committee, which is chaired by Patty Freilich and Jackie Mitchell. And we have a lot of people with diverse experience on that. And if you have an interest in joining, we would love to have more members. Just to be sure, you're here for the Navigating Palliative and Hospice Care Forum. If you're here for the Apple class, it's been moved upstairs. Earlier. Our format is going to be that Dr. Paul Blanchard is going to provide some general information about end-of-life decisions. Dr. Blanchard is a general internal medicine physician who's been caring for older adults for much of his career, and he has also had experience with hospice care. And following that, we're going to have two speakers, Courtney Brinkman, who is with North Star Palliative Care. She's a family nurse practitioner, and she will clarify what palliative care truly entails. Courtney began her career at a young age as a daughter of a hospice nurse, and as a teen, she volunteered at a hospice and a grief camp for kids. For the past 3 years, she's worked in home-based palliative care and hospice care. Chris Hurley, LPN, is here representing McLaren, Northern Michigan, and she is with their business development and sales supervisor. For the past 18 years, she's been working in that division, promoting McLaren's continuum of hospice care, home care, and palliative care. And she came to her experience with hospice and palliative care also from personal experience. Following their presentations, there's going to be a question and answer period, and all of you in the audience can ask questions, and we'll have about, I think, 15 minutes for that. And if you're on Zoom, you can put your questions in the chat and we will call on you as we're able to do that too. I also want to say that we have two other people in the audience who are here as resource people. Jennifer Johnson, who's a social worker at Bay Bluffs, which has an inpatient hospice program now, and Melissa Tanner from Advisacare, which has hospice and home care. So I will turn it over now to Dr. Blanchard.
Thanks, Martha. I've practiced here in Petoskey for 38 years. I've conducted many discussions with patients and their family members about, we'll say, end-of-life care. And I'm going to give an overview of some of the important points to consider in the realm of making medical decisions. Really, this is an issue of the patient's right to make choices about their health care. Hospice comes out of a history of people in the 50s and 60s, 1950s, 1960s, being when they were seen to be beyond help, they were kind of ignored. So honestly, hospice came about historically to empower people to have better care at the end of life when no more medical care or curative care could be provided. So the central point in making those decisions is an individual's value system, what they see as quality of life for them, what life goals are important toward the when life gets difficult, and that has to be the central focus. So it's really focused on the patient, their individual decision making, and to facilitate that decision making with knowledge of where they are medically in their life. Of course, as we all get older, our body's ability to withstand medical interventions and treatments becomes less resilient. And one big part of the things that I think about with people are I will give, if you're, the question is, can the older individual withstand a complication of what they're facing? So if a 60-year-old has a abdominal aortic aneurysm, something that could rupture and harm them, then it's not much of a decision to decide to go ahead and repair that. But if a 95-year-old has that, if they have one complication, it could easily shorten their quality of life utterly. So this issue of making decisions about care applies no matter what the overall picture of one's health is. An individual can say, I'm going to have every kind of treatment I can possibly have. I'm going to travel around the country to big centers to get evaluations and treatment. At some point in a serious illness, serious chronic disease, a cancer, what have you, the decision will need to be made. Am I going to keep doing this? What are my parameters for slowing down, backing off? Or who's going to be left to make those decisions if I don't give some guidance? So ultimately, this is a decision almost everybody faces. So when I talk to people about this issue, about these issues, we kind of start with the big picture. A lot of you are probably familiar with do not resuscitate orders. This is in reference to CPR, and often whether an individual wants to have a breathing tube inserted in their windpipe and be hooked up to a ventilator, where normally they are sedated in the intensive care unit and can't communicate any longer. So these are major interventions. They are, in many cases, last ditch life-saving efforts. So you start that's a topic that most older people can think about without necessarily having to have a specific diagnosis to consider in reference to those treatments. Then I kind of moved down to in other invasive procedures. Would the individual undergo a major operation? Would the individual undergo major, like serious chemotherapy? Or one question might be, individuals had a cancer in the past, they're cancer-free at this time. One way to ask this question to a older or elderly person is, if that cancer recurred and was metastatic or spread, what kind of treatment would you want in that situation? What would you do? Honestly, a lot of people, these are people, elderly people will predominantly, most people have told me they would not pursue real aggressive treatment if I posed that hypothetical to them. Individuals who had had a significant cancer in their past that was at that point thought to be cured. So that's a little tidbit. And then the next two layers of treatment would have to do more with maintaining chronic illnesses. Individuals who have congestive heart failure or diabetes or emphysema, you know, maintaining stability of those diseases is a comfort measure ultimately. Some people, and you know, historically, hospice has dealt very often with people at the end of life from widely metastatic or widely advanced cancer. And at that point, we're often talking about treatment that is really mostly comfort. But more and more and more over the last several decades, hospice has admitted people who have congestive heart failure or chronic diseases, for which maintaining stability is a comfort measure. The other thing is acute illnesses. You get the flu, an individual gets the flu, they have a sore throat, they have a bladder infection. As a provider in those settings, we treat those. As long as the person, you know, is not right at the very end of their life. We go ahead and we treat things like that, and often this kind of raises the issue of where one has treatment. This, I'll wrap up with this. Again, patient choice. Individuals should be able to choose, where am I going to have care? Do I want it in my home? Do I want it in my assisted living apartment? And very often with palliative care or hospice care, the care for even those acute problems that come up can be done in a home-like environment, at home or in assisted living or in a nursing home. So it's all about the individual being able to make their choices, and me and other healthcare professionals acting as a source of information about their condition and a facilitator in making those decisions.
Thank you very much.
Okay,
Paul.
it's pretty well.
That was great. So we will turn over to Courtney.
Yeah, so it's actually a really good segue there. So again, I'm Courtney Brinkman. I'm a family nurse practitioner, currently working for North Star Palliative Care, which is a subsidiary of Hospice of Michigan. So I take care of my patients through the whole spectrum of care in both palliative setting as well as hospice. Many people come to me from a referral from their primary care provider or a specialist like their oncologist or their heart doctor, pulmonologist, and they have no idea what palliative care is. And that's what we're going to talk about today, because most people don't, or have heard about it interchangeably with the word hospice. And providers are guilty of that as well, not using the right lingo. So very brief nutshell on palliative care, it in a sense is symptom management. What that means is very different for different patients. We are primarily a nurse practitioner driven organization and specialty in the healthcare landscape for kind of that gray area. When patients have a serious life limiting illness that is either requiring heavy symptom burden. So for example, a cancer patient who's undergoing treatment, they don't have to be elderly. I have patients in their 30s and 40s and 50s. I'm there to help support them with the symptoms that come from either their cancer or their treatment from cancer. And sometimes those patients graduate and don't need me again for a while. And sometimes those patients stay with me until I transition them ultimately to hospice care. We also take care of, so other serious life-limiting illnesses are things like COPD, heart failure, dementia is another one. And so what palliative care looks for those folks is very different than it looks for my oncology folks. And I think speaking in generics is kind of hard to wrap your brain around. So that's why I'm just going to kind of give the concrete examples to maybe help that make sense a little bit easier. So on the opposite extreme from cancer, because that's easy to understand, those patients have symptoms. We're helping to take care of things like nausea, constipation, or a lot of diarrhea, or they're not sleeping well, they're having pain, they're depressed, they're anxious, or they're having things that come up acutely and they can't get a hold of their provider. Because our cancer patients, we don't want them to have a urinary tract infection, or if they have a lung cancer, I treat an upper respiratory infection a little bit differently than I would an average person that came off the street. Those are one of the things that we can help with from a palliative perspective. Your palliative provider, kind of, I always say, it becomes like your provider in your pocket. You end up with access for our organization. We have 23 nurse practitioners across the state of Michigan that helps provide 24/7 on-call coverage. So that if patients or families have an issue that they don't know what to do with, like, do I go to the hospital? Do I ride this out? Do I go to urgent care? Is there something I can take? Shingles outbreaks often come up for whatever reason when our immune system gets suppressed as we get older, or in my oncology patients, that's a 90-second phone call. You call me, say, hey, this looks like I got some shingles. We talk about it. I take care, I send a prescription over and we're on to the next thing. With my dementia patients, oftentimes there may or may not be a lot of symptoms with those folks. And a lot of those visits are rapport building with not only that patient, but also the family members and caregivers. Caregiving is the hardest job on the planet, generally not paid for unless folks are able to afford some private caregiving. In this area, caregiving resources are really limited. Our supportive in-home resources are really limited. And one of the things that we can help do from a palliative perspective is help to connect you with what resources we do have in the area that are, whether it's caregiving, whether it's qualifying for Meals on Wheels or having rides to appointments. There's a variety of things that when there's options for resources in the area, we're able to kind of help plug you into those things. Like I said, we're a nurse practitioner driven organization. So I do have a palliative physician that covers palliative care across the state as kind of our mentor. But we have prescriptive authority. So we're here to be able to be that soft bedside touch that comes from having a nursing background, but also being able to prescribe for things that come up. So I don't know if that kind of helps clear up a bit what a palliative provider does. Our visits, again, are home-based, so we don't have an office. We go wherever your loved one or the patient is at, whether that's at home or in assisted living or in a skilled nursing facility. We're able to go in. Our role is very collaborative. We don't take over for anyone on your care team. When you're enrolled in palliative care, you're able to pursue active treatment. So for like my cancer patients, they want to continue for treatment, but they're having a lot of symptoms, or perhaps they're getting to a point where treatments we've kind of gone through and things aren't going as well from a treatment perspective. And oncologists aren't always the best at having those difficult conversations. They will oftentimes bring us in because we are kind of the experts in having those challenging conversations and not only saying to you, we need to get your advanced directive set up. We need to get what your goals of care figured out. I will sit there with you and help you figure that stuff out. We'll write them down, start to finish, signed, witnessed, notarized, done deal. We take those ideas and put them into action. That's part of our role from a palliative perspective as well. And to be comfortable in the discomfort, because talking about how we want our end of life to look like is something that we all think about at different stages. I will tell you that my very first advanced directive that I did for myself was at 20 years old. My risk factors for death are usually an accident, right? And I, as a nurse, knew that I did not want to spend the rest of my life in a nursing home on a ventilator. And I also was not married, and my parents don't get to make decisions for me. I'm an autonomous adult. So who makes those decisions? And I wanted to write that down so that if for some reason, heaven forbid, something should happen, I had that written down. Now, your advanced directive is a fluid document. It doesn't mean once you write those things down that it's set in stone, okay? Those things can change as you change over time. I think I'm on my third or fourth draft of an advanced directive because life has changed for me. So those are some of those ways to kind of help talk with patients and families about taking the scariness out of it. If I put that down, or if I say I don't want this to happen, then that's something bad might happen to me. And that's just not, I'm living proof that doesn't happen. So again, I think that, so again, palliative care is kind of that gray area. We're an added layer of support to help patients who have a serious life-limiting illness. The highlights are usually cancer, serious neurological issues, so Parkinson's, ALS. We actually have a fair number of ALS patients in the area, shocking amount for the population that we have. Dementia, heart failure, kidney disease, I'd like more of the end stage kidney disease. Some of our folks that are on dialysis are also some that kind of slip through the cracks and need a lot of extra emotional support. And COPD are kind of our traditional patient population. And those that are frequently ending up in the hospital because of those serious life-ending diagnoses, that we're able to then get a referral that can either come from your primary care provider, it can come from a specialist, it can come from, we have what are called friends and family referral. So you can go on the website right now and type in an email saying, I'm interested in learning about palliative care, or seeing if I have a person in mind that might be, and we have nurses that would then reach out to you and kind of talk through what is going on to see if maybe that would be appropriate. And then we take care of the paperwork, on the other side of things. From a reimbursement perspective, like how does palliative care get paid? We, from It's a little bit different, commercial insurance versus a Medicare, but from a Medicare perspective, we bill under Medicare Part B, just the same as any healthcare provider does. That's the section that where your primary care provider, your specialists, some people have a copay, some people, if they have an Advantage plan, do not have a copay. So there's the potential for a copay for our visit because it's an office visit. It's just in your home. The cadence, so frequency of visits, average palliative care visit is about once a month. If you need palliative care visits more often than that, then we should be having a different conversation. That's really a hospice level of care that we're needing. That being said, I have some cancer patients who I'm really working to titrate to get their symptoms under control, and I will see them more often. And some patients who have very stable symptoms that I'm only seeing every 2 or 3 months, but they know that my nurse then checks in on them regularly and lets us know if there's anything going on with them. We also have a unique system, it's called Bamboo, and it's one of those fun EMR type things that monitors for when our patients who are enrolled in our program are admitted to either the ER or the hospital. My nurses get an alert, and then my nurses are then reaching out to the patient and family member and saying, are you okay? How can we help transition from getting you home? And making sure that we're there in a relatively reasonable amount of time, and what else might you need to help support you be successful after this hospitalization. Again, similar thing from a commercial payer then perspective. So like Blue Cross Blue Shield, Priority Health, it's copay driven, kind of whatever your copay is set up is what a visit is. That being said, we are a nonprofit organization, and we do have a very healthy segment of our organization that fundraises. And so if patients cannot afford the copay that goes along with that, or they are not insured, then we have a financial support application to fill out, and we can help take care of those, the cost of that.
Great, well, thank you. We'll turn it over to Ms.
Awesome, thank you. Kind of at the end of this, and again, I guess we look at end of life and the beauty of what Doctor said and what Courtney said related to palliative care. Hospice truly is the end of life care, but it doesn't have to be only the final hours. As Courtney alluded to, when you're needing more visits in the palliative piece, then it's probably time for hospice. As we've all alluded to, yes, I've been in the business for over 47 years as a nurse and done hospice and palliative medicine, first with pediatric patients, and then moving on into the adult, and then moving on into this role to help educate the community. You all know about McLaren, and you know the good, the bad, and everything. But I have been here a very long time, and I believe in what I do and what we do as clinicians taking care of patients. Some of the things that were asked of me was, how do you make that referral to hospice? You can call us same thing with palliative care. You can call our office and we can come out and talk with you. We don't need an order to initially come out and have a conversation. If you feel after that conversation that this is what's right for you, then we would connect with your physician and say, do you feel this patient is appropriate? And we would get that order and get things initiated. It also can come directly from the physician. It can come from wherever you live. So you may live in an assisted living. As things change, or in a skilled facility, that referral can come from them as well, just for us to come out and talk. And then again, we do need that order to initiate services when it's time. So I wanted to make sure that you understood that part. And yes, hospice is end of life. But I think I'm going to give you a couple of examples because I think that helps most as we're trying to make decisions on what we want to do. It's not just for the final hours, which is we do see a lot of that as a hospital-based system across Michigan. We see a lot of very, very short, within hours of getting admitted to the program to get the patient comfortable. And I like to use people that I know. So I'm going to use my mom as the first example. My mom passed away 22 days shy of her 96th birthday. She was on palliative care for 2 years. Did not have a rehospitalization because her symptoms were managed at home. When it was time to transition to hospice, it was a very easy transition because she just didn't want to have any more. She's done. But the beauty of her story is we had her under care for 17 months. Hospice does not have to be for a very short time. If you choose that road, it can be a beautiful road because we're managing symptoms all along the way. As Doctor alluded to, if there's a urinary tract infection that comes along, we're going to treat it. If we listen to lungs and it sounds like we have a pneumonia starting, we're going to treat it. We're not necessarily going to send you back to the hospital though, unless you needed that level of care, because hospice does have different levels of care, which is a wonderful thing, because if we needed it, the hospital's right there for us. Most of our care is provided in the skilled world or assisted living world, and most of all, wherever you call home, because honestly, that's where most people would choose to be, is in their own home, unless, as Courtney had alluded to, in our region, there's a lot of people that are on their own and they cannot stay by themselves, so there may be placement, opportunities there. So again, hospice is an interdisciplinary, program, so you have a multitude of people coming to see you, managing symptoms. You have your physician that's part of the hospice organization, the medical director, as well as a physician who's involved, who is your primary or your specialist. They can all be involved and be consulted, say at the end of the day, guys, consulted, if we should need to do that, or you want communication back and forth with them. So I think that is oftentimes a fear. I don't want to lose my physician. Well, you don't have to. And way back when hospice began, you know, you didn't get to choose who you wanted to manage your care necessarily. Oftentimes you went to just a medical director. That's not the way the regulation works anymore. That's part of the admission. Who would you like to follow you under your services? So I think that is a very much eases the mind of those that are considering that, because you've been with doctor and you want to stay with doctor, right? So it can happen. Again, so you have your physician component, you have your registered nurse who is your case manager. So she's the person that's going to come and see you in your home, wherever that is, to manage those symptoms, to see how things are going, to help educate the caregiver in the home and work through anything that's coming along. You may also have an LPN visiting you as well, because they work together as a team. Social work, I think one of the hardest things for many people when they come into hospice programming is, I don't need a social worker because I don't need them going through my finances. Well, honestly, they're only gonna go through your finances if you need them to go through your finances, if you need help getting placement or getting applied for Medicaid or whatever it may be. They're truly another person to come into the home. This is one of those beautiful programs of life that really, as you transition, you've got people around you, you get to have those wonderful conversations. And that social worker is a great conversationalist, to be quite honest with you. And oftentimes we share with them what we might not share with the nurse. Again, then you have your home health aide, and they are the diamond of the program when you really think about it, because that's the person who is caring for your most intimate things, because they're bathing you and things of that nature. And I will tell you, that was the blessing when my mom was under hospice. I'm going to intertwine things as we go along. I was driving 2 hours every weekend to give my mom a bath, because I was the only one she would allow to give her a bath. And finally I said, you know, Mom, that we've got the hospice aide. It would really be wonderful. Then I can come and be your daughter. And she said, all right. Well, as soon as, and I'm going to name her, as soon as Kim came into the home, I was dead meat in that department. Because quite honestly, they developed an intimate relationship. She shared her things with her, and she would say to me, when I was there on weekends, thank you for bringing Kim into my life. You know, I really didn't think I could do this. So when you look at the whole group of people that are coming in, they're there as they end up being family. So that's why I don't want you to be fearful of what the program has to offer, because truly it is all inclusive. There's clergy involved, non-denominational. They're there to help you through whatever conversation you may like to have. And if you don't want them to have religious conversations, they're another wonderful person to have in your home, talking with you, sharing time with you. They bring treats and, you know, all the things that do really happen. And honestly, if you're Catholic and you want final rites, they're going to get a hold of your father and bring them in to do those things, because we're not taking the place of, we're just adding to that. Additionally, I think I got everybody there, but we also have your volunteers, the wonderful volunteers that do wonderful things, whether it be coming to your home and sitting and reading, whether it be that they're making beautiful blankets for you when you come under the program, whether it's out doing things like what I do, promoting what services are out there. They're all inclusive in our programming, because quite honestly, it's a requirement. 5% of our care has to be provided by a volunteer. So we need all of you as well. So I mean, if you'd like to volunteer, I'm sure any program that's here in the North would love having you. So that's really the interdisciplinary team. Hospice works in certification periods. So obviously there's the first certification period, which is a 90-day piece. And then there's a second one. So always think this: 90, 90, unlimited 60. But prior to that 60, starting in your third period, then a nurse practitioner or physician has to recertify you face to face. to ensure that you're still qualified, because we're certainly not gonna, people improve on hospice all day long. We discharge patients all the time because we've managed their symptoms, they're in control, they're feeling really good. And honestly, we want you to continue to live life, because that's what hospice really is about, quality of life, doing those wonderful things, going on vacation. My mom went through the tunnel of trees. There was just things that she wanted to do that we did all this while she was under hospice care when she came to live with me, because towards the end, she did come to live in my home. So now I'm gonna give you one more example, because Courtney did mention that we have to have those advanced directives. We need to know what your wishes are. Will we work with you on that? Absolutely, when it comes to DNR status, because to come to hospice, you do not need to be a DNR. Do not resuscitate. We can work through that with you unless we admit you at the hospital, and that's just a requirement that you have to be at that point. My father-in-law passed away almost 2 years ago at this point in time, he had a massive stroke. He had his DNR taken care of. He had his advanced directives taken care of. He had his durable power of attorney for healthcare. My sister-in-law Hannah called me, Papa's in the hospital. I don't know what to do. I said, Hannah, you have his advanced directives. She works for a lawyer. She helped him write them, but she's in the heat of the moment, right? And we all potentially could be in the heat of the moment. So make sure whoever you select is going to agree with your final wishes. But when you're in the moment, you doubt yourself. And as his daughter, she doubted herself. So she said, can you please just come to the hospital? So I went to the hospital, and she brought it out just like this. Like, they want to do this and they want to do that, but I'm trying to follow this, but I don't know if I'm doing the right thing. And I said, Papa gave you permission to follow this. This is what he wants. So we went through the first thing. Yes, we've accomplished that. Nothing changed. We went to number 2, nothing changed. We're at number 3. It's time for hospice, and he wants to go home to pass away. So we left he had only 24 hours with us by the time all of you're hospitalized and all the things come along. But he went his way with his advanced directives, and she felt so much better, because again, you doubt yourself, right? So it's just another story to keep in the back of your mind. Those things are so very important as you're working with your physician and traveling through all this journey called healthcare, right, in our life. So I just wanted to maintain that with you. Payment sources, again, your Medicare's, your Medicare Blues, some of your, depending on where you live. So if you live in your own home, your Medicare benefit, or your insurance, other insurance would be paying for our services. If you're living in an assisted living, you're already paying to live there. We just pay the care that comes in to take care of you, okay? Once you're in a skilled facility though, the payer sources are just a little bit different. Either you're privately paying, or you have a Medicare Blue. So we've done a lot of work with GM retirees. So if that were to be a benefit that you may have a 5th level benefit on that. Or Medicaid will pay for the bed because you're staying in that facility. So I don't want to mislead you. I want you to kind of understand that, because as life moves forward, those are good things to know. Location, like I mentioned, can be anywhere you call home. Independent living centers, with assistance with private duty. You may need additional services of private duty along with your hospice care. We're not going to take that away. A lot of people worry about that because, well, I have Jenny coming in and she's doing these things, but we're not going to take Jenny away. We're going to add to the care you're already getting. Same thing within the skilled facility and the assisted living. We're not replacing their care. We're adding to that care, but we do manage the care. Again, who can order the services? Your primary care physician, an ER doctor, a specialist. Any physician can order the services, and then again, we just assess to make sure that you're appropriate. And then the final thing that she had asked, I'm probably going a little quick, but to give you an idea of the services that are in the area, hopefully I don't miss anyone, but it is obviously McLaren Hospice, Hospice of Michigan. Munson has a hospice program. Advisacare, who's here today, also has a program, as well as Compassus. There have been a couple others in the area, but I think some of them are kind of dwindling away, so I don't want to lead you in the wrong direction if they're no longer in the area. If I've missed one, raise your hand and let us know. In closing though, I want to just say a couple of things. You've worked your whole life building your chapter or building your book of life, right? The first chapter is birth. The second chapter, you're a toddler. The next chapter, you're a preschooler. Then you're in kindergarten. And then you're in, we travel along. But your final chapter of life, this is what I'm talking, hospice program should be an accumulation of all that happened before it. So write your final chapter now so that you know what you want as the future moves forward. One other thing I'll take with you, because being in this business as long as I have, the fear word is hospice, morphine, dying tomorrow. I want you to, from now on, move forward and think of this. The hospice is the word HOSPICE. Take out ICE, you have HOPE. I look at hospice as the program of hope, because now you have the hope to have your family around you, to write your own chapter, to be free of pain and, you know, have your symptoms managed, and to live life and have quality of life for the duration.
Thank you all. That was a lot, right?
Well, that was a lot.
This is obviously all things that many of us have already dealt with our parents or other family members, or we need to be thinking about for ourselves. So, I'm sure everyone's got lots of questions. I'll do my best to field the questions, and, Eileen's gonna be tossing me ones that are coming in on the Zoom chat. So, does anybody have a question for our panel or our other resource people?
I have a question because I think it was Courtney, you mentioned about dementia and Alzheimer's
Yeah.
patients. In many instances, they live long lives. So at what point would,
What time do we
Palliative
plug
care.
palliative care in? Yeah, so that it depends. So some patients at time of diagnosis, when they get that final initial, that official diagnosis, whether that's coming from neurologist, your primary care provider, or they had the blood test, right? That's been coming up a lot lately. I had the blood test, I've got Alzheimer's dementia. Our goal from a palliative perspective, from a programming perspective, is to look at that moderate. So it's kind of that middle of the road. We use different tools to try and say, where are we at in that dementia trajectory? But essentially, if you have that diagnosis, you're struggling with some type of symptoms, whether it's you yourself or your caregivers are seeing something, it's never too early to bring us in from a palliative perspective, because sometimes we just come in and say, you know what, it really is a little soon. That's happened before, because we don't have a ton of symptom burden. We don't necessarily need to, but I will come and we're gonna need me at some point. And so we do touch points. And so we check in regularly, because as we start to lose our memory, we also don't recognize people. I would rather you recognize me and have me be a familiar person, to have that rapport building. It's a whole lot easier. From a caregiver perspective, the caregivers, the family is gonna get the most benefit out of that support. Because you don't know what the right thing to do is. How do I need to set up my bathroom? How can I make my home safe? How can I work out some of these logistics? And those are the nice part about palliative care from a provider perspective, and I think my patients benefit from it. I'm not tied down to a stopwatch. You know, you go in and see your primary care provider, your neurologist, we've got 15 minutes, we hit the highlights, you're out the door, on to the next. I'm here to sit in the weeds with you and help work out the logistical stuff that they may have said, yes, you need to work on, you know, make sure everything's safe. I'm gonna come into your home, these rugs, we've gotta go with that. I had a patient that had glass shower doors and was falling on Eliquis. Bad idea, because most of our falls happen in the bathroom. So can we maybe just turn that into a rod and a curtain? And so it isn't always a medicine I'm prescribing or that we're prescribing from a palliative perspective. It's some of that life logistics that we can help with. So to answer your question, dementia is a hard one because there's a range, and the different kinds of dementia present differently. So a classic dementia is that Alzheimer's, where we're starting, oftentimes we don't get plugged in until the caregivers are way burnout, right? We're incontinent. We don't recognize, or we've had some safety issues where we've wandered. That's probably a little late, but it's oftentimes when I get plugged in. Vascular dementias are even trickier because they can be very normal one day and the next day or 4 hours later, vastly different human being. And your providers are great, your neurologist is great, is oftentimes explaining what that looks like. But when you want to really know brass tacks what that looks like and how you can help evolve your world now to help make things as safe and as comfortable for your loved one as you can, that's kind of when you want us to get involved. And so it isn't always going to be, we have to, if you bring us in too early, we're going to say, no, this is never gonna happen, but how often do we really need to be plugged into the mix, and here's where you get started.
And I have a comment. It can become very burdensome taking a person who is suffering with Alzheimer's disease to physician appointments. So at some point, it's really becomes problematic. So Courtney and her team come to your house. You don't have to have an appointment. You're not sitting in a waiting room with someone who may be getting a little feisty or a lot feisty. And just as a next step with that, a lot of people have the lung doctor and the heart doctor and the skin doctor and the eye doctor and the kidney doctor and everything. It's good to work with someone, and I think Courtney and her team would be very good at this. It's saying maybe it's time to not go into the kidney doctor every 6 months to have a brief checkup when everything is relatively stable. So when the burdens of having traditional outpatient care become great, it's a good time to have palliative care.
Yes. Kind of a long time ago, like back in the 90s, when I was working as a pharmacist, I'd have patients on hospice. And back then, one of the really great things was the hospice would provide services to the family, not just the patient. Is that still?
Absolutely. We follow you for 13 months after. We can help with individual support, come to the home. We can help with groups. We have groups as well. And there's a lot of phone calls and a lot of mailings, but absolutely. And I think, we talked briefly, Doctor and I, before it started, oftentimes we get the patient at the very end, the bonus of it's a hard thing to have to sit down and sign papers. I understand that completely. But one of the things to think about is the surviving family in that type of situation, because we are going to follow them as they travel their journey. So you're 100% right. Yes, bereavement services are part of the program. Yep.
And you don't have to have been, I believe
You
it.
do not have to
not
have been
to
on
actually have
hospice.
had a patient in hospice. If you're bereaved
Yes,
from a death that the person wasn't in hospice, you can still utilize hospice services.
absolutely.
I would also say that being in hospice, people need to be in hospice several weeks to have the post-death benefit of less depression, less bereavement burden,
Absolutely.
again, in general.
Well, we know scientifically, when we look at numbers, they've done research, and when we plug people into hospice programming sooner rather than later, their quality of life increases, which we've talked
Right.
about, but also their length of life increases exponentially. And that's also part of, my role from a palliative provider perspective is watching for when we really are ready for that and helping you make that transition, making hospice not feel quite as scary for both patient and family. So like I said, like we introduced in the beginning, I'm also, I always tell it to my patients, full disclosure, I'm the daughter of a hospice nurse. I've been in this world for a long time. I'm very comfortable in that world. But I want you to be comfortable in that world too. So when I say I think we're ready for that point, I want you to be able to have that max benefit too, because it's truly a benefit.
It truly is.
We have a question from Zoom.
Yes, can you please talk about support for the caregivers?
Yeah. So I don't know.
Absolutely. Throughout the whole journey, we're going to be educating and supporting you. That's why I mentioned all the interdisciplinary team. And the reason why I say that is we often have families when they come under the program, think, well, I only want the nurse. They're not looking at the whole picture of all the support that comes along with that, because truly you do need those extra people coming in out to see you and allowing you to vent as the caregiver. What's next? Why do I feel this way? That's why that whole interdisciplinary team has been put together from the beginning, is to ensure that we're managing all those things or helping you through that. If it's something that we can't manage, oftentimes the depression or things are more, we're going to refer you to the right professional during that journey as well, because sometimes we need to work together to ensure that you're getting what you need as you move through the program.
And from a hospice perspective too, part of that benefit is your respite benefit, which I think you touched on a bit. That's one of the roles I worked as a volunteer when I was in high school was, your folks need to just go and do their own doctor appointment. Wife just needs to go and have go get a massage, go get her hair done, go run
Absolutely.
groceries. And that's where those volunteers in the hospice program can get plugged in
Mhm.
and spend time, ideally from my experience in a couple different hospice programs. They try and match you up with volunteers that either have similar interests as that patient. So if they were, you know, a musician, have someone that can come and play their guitar for them. Or was a reader and they have really bad macular degeneration, haven't been able to read in a long time, and just having someone read with them, that's tremendous relief off of care. Every time the caregiver can check out is a great
That's a
thing.
good thing.
From a palliative perspective, you know, we don't have that all-encompassing program, which is oftentimes how I, you know, manage to get people to, if we need all that all-encompassing care, let's do the hospice piece. But the resources of the community are something that I have to stay up and familiar with, and we have resources that you'd be surprised that we have access to. Even our Emmett County, Charlottesville County Sheriff's Department have a program called Life Saving Program, that they actually are able to get care trackers for patients with dementia. So that way, if we live in an area without great cell service, which most of my patients live in areas without great cell service, they have GPS capability, because unfortunately, elopement happens, they get lost, and unfortunately, we lost a gentleman a little bit north of here because he had dementia and was out going and doing his normal walk and never made his way home. Which is the sad reality of what can happen with those folks. But know that there's usually more resources in the area than we realize, and that's what we're here to kind of help activate for. Caregiver support groups. Every community, Boyne City has a really great Lewy body dementia support group. So when we get plugged in, we kind of help provide that resource. If your friendship centers, so your senior centers all have great lists of dates and times and locations that you don't have to be physically present for, because it's difficult. The organizations, so like if you have ALS or Alzheimer's, like on their own website, there's often links for caregiver support and meetings and things, and people are like, I don't have time for a meeting, but the benefit on those caregivers that do go in and either leave the home and go into that meeting or just the tips and tricks they hear from others that have been through it, is a tremendous benefit. So hopefully we helped cover that.
And Courtney did mention distance, and there is a lot of rural patients here. One part of our programming is also that we do have a iPad that we leave with the patients that live out. So that in the middle of the night, if they're calling us, we're coming out to see you, but that you panic, well, that we're this far out, or we live way down this road, no worries, because we're gonna be communicating with you so that you could see us and communicate back and forth until we arrive. And I think that's one of the things that we've added into our programming recently across the state, and it's been very effective for those patients. Additionally, I don't know whether you've heard of VR, virtual reality. You know, your kids or your grandkids have those little goggles that they like to wear. Well, in hospice care, it is one of the newer things nationally that's been brought about, and we do have that capability to bring that into the home. And if your loved one wanted to go to Paris and they're not gonna get there, we're gonna take them to Paris on this virtual reality piece. If you wanna go to the beach, we're gonna take you to the beach. Let's say they live in a facility and they really just wanna go home. We can GPS their home and take them on a ride home because they're not able to get out. So there's a lot of things coming along in healthcare today that help with these programs as well. So that, again, we're living a quality life as things move forward. One other thing I did want to mention, I did bring a few packets for you back there. There is a book in there called Hard Choices for Loving People. And many of you may have elder parents that you're working with or trying to make your own decisions on, what do I want? Do I want a feeding tube? Do I want an IV? Do I want CPR? The book was written by clergy. His name is Hank Dunn. He's quite a phenomenal individual. We've had him at one of our locations downstate, come in from Massachusetts to speak with us. He wrote that book in very easy language to help you make those decisions as you're working on your advanced directives and going and talking to your physician on how to get there. I think it's just a really great resource. So I've shared one with all of you, and please share it with your family. As Courtney alluded to, you need to start thinking about these things young, making those decisions. You can change as time moves forward. Over time, people move away. You may want to select someone else as your durable power for healthcare. So there's just a lot that will help guide you as you're trying to make those decisions.
Thank you. Nicole, yeah.
So I'm wondering if Dr. Blanchard or even Jennifer wants to address the issue of our hospice house closed here a little bit over a year ago, but now there are some specifically designated hospice rooms at Bay Bluffs, and I don't know if people know about them or how to access them or how that piece.
And can you repeat the question for the Zoom audience? They're asking us to repeat.
the question is for a brief description of the Bay Bluffs Hospice Suites.
And inpatient hospice care, 'cause that Bliss too, Bliss Cottage,
Right, there,
Oak
yeah.
Island, yeah.
The suites are basically 2 rooms. There's the bed and a sitting, nice chair on one side for the resident. On the other side, there's like a sitting room, like a couch, TV. The couch pulls out to a bed if the family wants to stay there. We have, I believe, 4 suites right now set up, for the people that are more end of life. We have other hospice residents there that are not that close to. And the other rooms are set up quite nice too. The suites are just a much larger. So if 5 or 6 family members wanted to be there in overnight, they could be there and not disrupt the resident too. Off of their own time.
But you don't have to be an inpatient at Bay Bluffs to access a suite, correct?
No, they usually come in through, one of the hospice companies.
So we do like and I know it's the same for McLaren as it is for Hospice of Michigan, we do, part of your hospice benefit is a respite, so up to 5 days. Where during a certain insurance cycle, and that's why you have a social worker to help navigate that, where a family who's at primarily taking care of patients at home need a break, they're going on a long vacation, they're going to someone's graduation, and they want to make sure mom or dad or whomever is taken care of, your social worker can help coordinate a respite stay, either at the Bay Bluffs area, or there is the other skilled nursing facilities that do accept like a respite benefit, that your hospice team, and you could probably speak that better on the financial part, helps pay for that. So that way you have that break, and it doesn't have to be 5 days, it can be 2 days or 3 days, but that is a regular part of your hospice benefit as you go along, to get that break. And the hospice homes were designed, those are was a huge tragedy, obviously, for our area to see that go away. It's kind of happening across the country, so we're not unique to that. But the goal in having that is when patients are really high acuity, I mean, they're really sick, their symptoms are really, we're having a hard time getting them under control in the home. Maybe we've taken them to the hospital and now we've got things to calm down. And then they were putting them into that where they could have kind of constant monitoring and care by someone else, by a trained professional. That was kind of the benefit in having those hospice beds and hospice rooms, and why we would want something like to access the hospice rooms at Bay Bluff. But also too, I had a patient who I had under palliative care for a very brief window of time, really needed hospice, but nobody could get him to sign on. I did, but I won. But the wife was scared because she's like, there's no way I can take care of him. There's no way, if he goes on hospice, there's no way I can take care of him. I'm like, you're taking care of him right now. And if you go on hospice tomorrow, he's the same human as he was today. So when when it became too burdensome, because everybody has their line in the sand, like if someone becomes incontinent, or if they're needing a lot of, it's too much, they're around the clock symptom relief and they need someone else or someplace else to have that hospice. Then we have the options that we do have with Bliss Cottage now, that's now where Highland used to be, as well as Bay Bluffs here locally, but other facilities in the area throughout, because I think we're covering Sheboygan through.
Yep.
I don't remember the territory that we were.
Sheboygan and Emmett, yep.
There's, Medi Lodge does the same thing where we can get you plugged in there, or the what is it, East Jordan? Grandview.
Yeah, absolutely. And understanding that the hospice benefit in these skilled facilities that we're contracted, all hospice agencies are contracted with them. And so therefore the respite benefit is part of the hospice benefit. So there's inpatient level of care, which I mentioned earlier at the hospital, can only be done at the hospital. And again, those are symptoms that we can't manage, that we need to get managed to get them back into their home setting. The respite benefit of 5 days with your cert period. So again, you talked about caregiver burnout. We need to use those benefits. That's what they're there for. And when you don't use them, and you become burnout, people are kind of stuck in their ways, right? And the same thing with even having us come into their home. I don't want you to come to my home because I don't want you to know that I'm a hoarder over here with all my books I read, fluently all the time. And I've got 100 books in we're not worried about the books in the room. We're worried about just coming to take care of you wherever you call home. So understand that part. So respite is a wonderful benefit, underutilized. by many. Because again, they're fearful, but as Courtney alluded to, you can go on vacation, you got a 5-day piece. And then if you stayed 7 days, then there would be an out of pocket cost for the family for that extra couple of days. But at the end, but 5 days are paid for by hospice 100% on that. So it's just a beautiful benefit.
Christine's had her hand up for a while.
I'm sorry.
Yeah.
So I just wanted to share because I volunteered at hospice for a couple of years, and one of the services that we offer, not physically related, but was helping people tell their life story.
Yes.
And so we would meet and interview, we use photographs and interview people and then put together a book for them on their life story. And you don't need a volunteer to do that, a family member could do that with them. It was really, really special, both for the person who was reliving some of their
Absolutely.
memories and then for the family when they passed. So I just wanted to share that. It's a
Yep.
softer side.
A softer side, yeah, there's a lot of beautiful things, and it's still, we still have our quilters making quilts that we give to all of our patients, no matter where they are, so there's just a lot of good giving in the volunteer department, so we're always recruiting, because it does make you feel good, to give back.
I have a question that's probably for Dr. Blanchard. What would be the reason why a primary care physician may decide not to be the hospice doctor for someone versus the medical director?
Help me.
Good question.
Well, I always wanted to be keep my role as the primary doctor, but. Outpatient, if this is an outpatient practitioner, they've got a tremendous amount of time pressure on them. They're doing lots of administrative work along with their seeing patients in the office, and there comes a point where lots of hospice patients, as I alluded to earlier, don't go to office appointments anymore. So sometimes you get involved with the doctor not wanting to answer a lot of questions and deal with things over the phone. The other thing is the hospice medical director is really good. The primary doctor knows that and has full confidence in them, and it's a better arrangement. So that's a couple of reasons.
Question over here?
What?
Middle
comment.
call.
So Dr. Blanchard's helped me get my wife into hospital. One of his selling points, which was a hard decision for anybody, is I can go from being a caregiver back to being a husband again, which is a completely different phase of life for me.
Absolutely.
Secondarily, I'm a new pastor, but I started a caregiver support group in Boyne City to church there. We're not doing is not religious at all, but we're encouraging members to come and really share stories based on some work a friend of ours doing in Harbor Springs.
That's wonderful.
This issue of the role of the family and the caregiver role has come up a number of times. I would like to say, especially in larger families, if there's a healthcare professional in the family or among the caregivers, it's good to just think some families might look to that person to be an expert, a helper, more of a caregiver. Think about letting your healthcare professional family member be the family member and not the caregiver.
I happen to be married to a primary care physician and I have a 99-year-old mother, and Courtney Brinkman is my mother's primary care provider. So he needs to be my husband.
That's right.
So I just wanted to share one thing as we think about the role of palliative care and the role of hospice. Because I think oftentimes people have a preconception that palliative care is like pre-hospice. And I don't really believe that. I think that's a myth. And my direct experience with several family members that have had serious illness kind of demonstrates why. And I feel like it illustrates the two things that are always pointed out to me about when it's time for hospice. And that is that for hospice, you need to be eligible, and then you need to be appropriate. Okay. And then if you need that extra layer of support, but you're not eligible and appropriate, then you have the opportunity to use palliative care. So one example I always give is my husband in his 40s was diagnosed with head, neck, and throat cancer and needed a combination of radiation and chemotherapy that is extremely, extremely hard on the body. Just absolutely brutal. And he was a very healthy young guy, right? So he was not eligible for hospice. He was expected to survive. So he certainly didn't meet the criteria for eligibility, which is 6 months or less is the predicted amount of time that the person will live. So because he wasn't eligible for hospice, but he had a high symptom burden and a lot of issues going on at home because I was a young mom, we had palliative care, which was fantastic. The other example is that my dad had ALS and he was at a certain point eligible for hospice, but he felt really good and was still pursuing treatment at the ALS clinic and didn't want to give up any treatment options, right? So he was eligible, but he wasn't appropriate. And he utilized palliative care, especially social work, to come in and help my stepmom know how to coordinate all of his care, know what equipment he needed to have at home so that he could continue to move around and get out of bed and use the bathroom and all that stuff. So palliative care was great in that scenario. And then my mom had lung cancer. And after she said to us, I don't ever want to go back to the hospital. And we said, okay, if that's really your biggest concern and your number one priority, then we know that you have to stop doing chemotherapy, right? So she was then both eligible, 6 months or less to live, and appropriate. She didn't want to do any more treatment for her cancer. And then she was on hospice for 2 months. So, just like some examples to me that like make it clear, like which, how do I match my treatment goals and my diagnosis and prognosis? How do I match it to either palliative care or hospice?
Excellent.
Okay, thanks for sharing.
Yeah, thank you.
Yeah.
Yeah, that was great. Question there?
So you've done a great job sharing fantastic resources kind of available in northern Michigan and around Michigan. Where would you direct someone if they need to explore options outside of the state? Let's say if someone resides in a different state, maybe they winter in Florida, kind of those things. Is there national websites that are good for kind of identifying hospice and palliative care resources? So I'm seeing no.
No and yes.
Yes.
So there's many companies that are national companies.
Yep, so the question in the audience was for people outside of our local area or outside of our state, how can we look for hospice and palliative resources nationally? What does that look like? And are they up to date? Are they out there? Because there's from a palliative perspective, there's the coalition, it's CAPC, CAPC, that is a palliative care, supposed to be directory. I will tell you it's not 100% up to date. And there are different, this is what makes palliative care super fun and gray. There's different shades of palliative care. And that can be state-based, company-based. There are some shades of difference there. What I usually say depending on what the diagnosis is, like, so I have patients who winter in Florida and we help coordinate that transition so they have palliative care both in Florida as well as with us here. Their number one resource is their oncologist, who knows them and who knows the area and who their preferred palliative or hospice provider is. And honestly, it's, Google and reviews that oftentimes help drive that, because the directories, I'd like to say, are up to date, but they're not always super accurate from a palliative perspective.
From a hospice perspective, if you live here during the summertime and you go to Florida for a couple of months and you're still eligible for the hospice benefit, then we would just work with an agency wherever you are. And so it would be, we call it travel contracts, and we would just ensure that you're getting the care you need while you're there until you come back. So there's a lot of things like that out there for you.
on your loved one's primary care provider, ultimately, because they're the quarterback on their
Right.
team. You know, what teams do they, what hospice programming, what palliative care programming do they have in their area? And then let you kind of, you know, get the list and work from there, because it can be difficult to navigate who's what, because there is, so let's say another gray area that also occurs in hospice care is under pediatric hospice. So we have one of the pediatric hospice programs in the state. And pediatric hospice is different than adult hospice because pediatric patients can still actively be pursuing treatment while they have that hospice benefit. And so there is some shades of gray in both the palliative world and the hospice world in that regard too.
And just another random question, what if someone hypothetically, hasn't seen a medical provider ever? I love that. Not myself, but hypothetically, someone, a friend of a friend. I'm assuming that's a situation where if they're having issues declining, they would likely go to the ER if it was an acute event and needed to kind of figure out a plan of how things are gonna be managed, like if they don't want treatment, but they're having excruciating symptoms, like I'm assuming that's an ED and they would assist with the coordination of getting them something at home.
Because yeah, it would be difficult to get both either palliative or hospice level of care without diagnosis.
Right, you gotta have it then.
And so oftentimes it's, you know, they've been very short of breath, they're losing a bunch of weight, they go into the ER, they get a chest x-ray, they're full of tumor. We don't want to do anything else with that. And then the ER coordinates what happens after that. Yeah. Which is not the best use of an ER. because you
Yeah,
have a primary care
highlighted,
provider.
and it's not ideal, but I'm sure everybody knows.
Oh, we all have,
some-
There.
and there are sometimes healthcare workers. Are some of the worst.
And you mentioned that you can update your advanced directives. Do they have to be notarized every time?
Only if you change it. So on most, and that's where it gets, so you can hear, can the Zoom people hear what you asked?
Maybe not.
Okay, so the question was, when you update your advanced directive or you renew it year by year, decade by decade, when you go to re-up it, does that need to be notarized? So on most forms, and that's where it gets hairy because there's a lot of forms out there. You can go online and find an advanced directive or a 5 wishes, or every health system has like their own variation of an advanced directive. If everything stays the same, it's just, there's a page on there where it's just, you update your signature and you date it. Like I verify that this is what my continued wishes are. If you want to change anything, you want to change who your patient advocate or a secondary patient advocate would be, or you want to no longer be a modified code, meaning you want some things, but don't maybe want prolonged ventilation and now you know you don't want any of it. That's only paperwork, unfortunately. The other piece that we haven't talked about is, I believe it's nationwide, but I know for sure in Michigan, we have what's called a POST form, formerly POST form. It's an acronym. So physician's order for life-sustaining treatment. And it doesn't have to just be a do not resuscitate. It can take your wishes and put them into physician order form. In our area, they tend to be a bright pink form. EMS is trained to look for them. We like them posted when I tell my patients at home on the refrigerator. So if a neighbor happens to come by and they look like they're just taking a nap in the recliner and they're really not, and they call an ambulance because the neighbor doesn't know what's locked in your safe in the bedroom. Neither does the EMS guys because they're going to do everything. That kind of takes that as a stop sign for the EMS, as well as you can have things on there like no blood products, or I don't want a feeding tube under any circumstances. There's lots of room to have that done, and your primary care provider is the best person to have that form signed.
I just wanted to follow up on the post form in Illinois where I worked. We call it the POST form, and I was on that state committee. So the biggest thing with that is that some people think that if their power of attorney is present in an emergency, or if their living will is there in an emergency, that document is going to speak for the patient when they can't speak for themselves in a critical medical emergency. And the fact of the matter is that's not the case at all. So in order to tell emergency first responders what you want or what you don't want, you do need to have one of these forms, either an out of hospital DNR form or post form. And what I think is really great about those documents, first of all, they do need to be completed with a qualified healthcare professional and the patient or the patient's agent, power of attorney. And there's two sets of decisions, right? Because like a DNR is like, your heart has stopped, you have no pulse, you're not breathing, what do we do? And so for some people, they might easily say, I don't want you to resuscitate me, right? But what if you're not in that situation where your heart hasn't stopped, you're just really critically sick? Well, you shouldn't have to, like, you don't want people to believe, well, don't treat me because I said I don't want to be resuscitated if I'm dead, right? Like, I'm not dead. So I might want a whole bunch of different things. And so what this form does is it gives you choices that if your heart is still beating, you might want to restrict certain things and not restrict other things, or you might want everything. And then if your heart stopped, you want them to stop, right? That's a legitimate decision. So this medical order is something that first responders and people in the emergency department can act on.
Yeah, I'd say I like the post form. I have done one myself quite a long time ago when I was younger. And as a younger person, I anticipate, I want to kind of be helped to get back in because I'm going to live another 40 years.
Right.
So it has a whole lot more nuance and all those different levels. And so if you haven't seen one of those, I would urge you to do that. We do have to wrap up because we have to literally be out of this building at 7. So we want to thank our presenters.
And I just want to remind people that we will have another in-person league forum meeting on Wednesday, November 5th. We try to do second Wednesdays, but in November, it will be a first Wednesday because we like going to the tribal center in Harbor Springs in November, and we'll have Julie King from King Orchards talk to us about the effects of federal policy on agriculture and probably climate change. So it's advertised right now at 5:30. Look for the announcement in your emails that might move it to 7. I apologize that we don't know the exact time. I'm looking around at board members. We didn't come to, our pre-read minutes didn't come to a conclusion. It's definitely Wednesday the 5th at the Tribal Center with Julie King.
And there will be refreshments.
Yeah, they're always. Thank you all so much for coming and thank you, Danielle.
That was so interesting, you guys.
Yeah.